Thank you, Patty, for that introduction, and thank you for inviting me to speak on this issue. It is, in fact, the first time I've specifically spoken on the issue of devolution. I've always been, for 30 years, I headed up, as you mentioned, the Kirkton Road Centre, which was the government's headquarters in Sydney's King's Cross, which, if you've ever been to Australia, that is the area which has long been the centre of the sex and drugs industries in the country. It was established, Kirkton Road Centre was established by the government as its as having its public health responsibility for the vulnerable populations centred in that area, and I've had the privilege over many years of being the director of that service. And so long enough to experience the changing tides in our approach to health. It does seem in Australia, like maybe other countries, that now and then the government decides it wants to restructure the health service. So we go from centralised approaches to devolved approaches back to centralised. And I suppose in 30 years I've lived through quite a few of those, and pleased to say I've survived. But public health most certainly is the thing that has needed to be sustained throughout those structural changes. So I give a perspective from someone who's worked at the sharp end of public health in this particular area. So what it tends to, devolution, what that tends to refer to is the decentralisation of public policy decision-making, usually along with budgetary control. Started in earnest in the late 1990s, right across certainly the Western world. Usually enables different models. I think the United Kingdom, with its different areas, is a good example of the different types of models that are possible. Also, though, complicating, generalising about this approach as far as whether it's good, bad or other. It can involve various spheres of government, not just health, but it's certainly in healthcare that there's been special interest, and I think that's connected to the burgeoning health budgets in affluent countries with ageing populations. And as already flagged, ensuring that public population-focused health is maintained has been a particular concern when these sorts of structural changes occur. In Australia, the way the health system is structured, it's slightly complicated and not all that logical necessarily. Public health has been the responsibility of central government, federal government, based in Canberra, whereas hospital-based services have been the responsibility of the states. Meanwhile, primary health care has been funded on a fee-for-service basis at the national federal level, and is covered under a universal health insurance system referred to as Medicare. We've had triennial or 3-yearly strategies, national strategies developed for HIV, Aboriginal bloodborne virus and sexually transmissible infections, hepatitis and drugs. And they first started being developed in the late 1980s. The federal government would give the states money to address those, to implement those strategies on the proviso that the states would match that money. So they had to match the investment from the national level. And the funding would come with obligations to monitor and achieve nationally set key performance indicators for each of those strategies. So in that way, they controlled the direction of those national strategies. However, we are now moving away from 3-yearly strategies, and in fact the current national drug strategy is a 10-year strategy, the implications of which we're yet to see. So my talk is going to pose many more questions than it answers. I'm more or less going to scope what the issues might be. I don't come up with any answers for you, but I suppose the central message is the need for balance in our approach. So the questions: how does the state decide how these resources will be allocated? Is it based on the size of the state's population? Is the population's demographic profile factored in? For example, the age, Indigenous status. In the case of Australia, we have a very significant Indigenous population with significant public health needs, and that is not a population that is evenly distributed across the states and also not within the states. So are economies of scale factored in? So is it just on a per person basis? Maybe the bigger states like my state of New South Wales should get less because we can enjoy economies of scale. Is the current and the future disease profile considered? So the needs of the state's population. Do we then measure the outputs, i.e. the activity of health services, or do we measure the outcomes? Outcomes, of course, much more difficult to measure from a public health physician perspective, much more important than activity. So how do we measure those things? Which things are measured? Are surgical waiting times, for example? That is something that hits the front pages in our country all the time as something that's of great concern. Waiting times in emergency centres is another thing, but arguably more politically important than from a public health point of view. We rarely see the incidence of HIV in vulnerable populations covered on the front pages of our newspapers. And how do we respond to the non-achievement of those outcomes? Do we penalise areas that don't achieve outcomes, or do we give them more resources so that they're better able to achieve those outcomes? Or is it all just historically based? It's a zero-sum game. There's only so many resources, so increasing resources for one area necessarily means reducing resources for another. Anybody that's worked in the health system will know that there are very strong interests, I hesitate to say vested interests, but moving resources away, particularly from the medical profession, of which I'm a member, is very, very difficult indeed. How is the appropriate balance between disease prevention, health promotion, and acute short-term and chronic long-term treatment and care decided? So yesterday, Jeff already put up these 7 words. So these are obviously relevant to how political all of these decisions can be. The banned words there on the left, Kevin Drum, a political satirist, has suggested replacement words. I'm not sure that this will translate very well into Ukrainian, but at least the English speakers might know what I'm getting at with a somewhat tongue-in-cheek facetious slide like this. So yes, it can be very political. So the advantages and disadvantages of localism. So localism being a terminology referred to when decision-making is devolved to that local level. So arguably it's more responsive to local issues. Local stakeholders with the greatest understanding of local conditions are able to proceed to apply locally appropriate solutions to local problems, unhindered by those less acquainted with their situation. And certainly my experience as the medical director of the medically supervised injecting centre established in King's Cross was a good example for me of where a local solution was appropriate for a local problem. We had all stakeholders on side in that local area, but the fact that it had to go to state level because legislative change was required meant that we had a raging state debate. People in areas unaffected by drug use were worried that an injecting centre would be established on a street near them. And in this instance, I felt very strongly that it would be more appropriate that local government have jurisdiction over this type of facility. But on the other hand, there is a risk of parochialism. This localism approach is less top-down. It encourages grassroots initiatives such as the injecting centre in my case, and it also potentially allows for greater autonomy, but there is the risk of local areas going rogue. It's arguably more democratic, responsive to the voice of the people in the local area, but does that in fact favour populist views? Is the loudest voice at the local level always the majority voice? And is the majority voice always right? In the case of the injecting centre, We did polling of local opinion because we found at community meetings there would be very loud vocal opposition to this. What we found when we did random telephone polling in the area was in fact that those voices were not representative at all of what the local population thought. In fact, they were very supportive of an injecting centre, and I'd have to say that evidence, unlike some of the other scientific evidence, was very compelling for local politicians of all colours. Once they knew that 80% of the local population supported this thing, interestingly, there was multi-partisan political support for establishing this service. But what if the results had been different? What if the local population had been unsupportive? Would that have meant we couldn't have gone ahead with this important public health initiative? So what is the role of professional, expert and those with lived experience versus local community stakeholders? Very commonly in local communities, there's not a voice from the affected community. Drug users are not always well positioned to have a voice at that local community level, particularly given that the behaviour is still very stigmatised, illegal. It's unsurprising that they're not necessarily sitting at the table. So who represents their voice? Those are important questions. Who has the final say? Advantages continued can encourage healthy competition. When things are devolved to the local level, I think in the UK, in the documents early there, it was referred to as constructive discomfort. Do you like this political spin language? Especially if combined with purchaser-provider arrangements that can create a lot of competition at the local level between organisations vying for limited funds. That is a risk, therefore, of reduced collaboration and partnership approaches at that local level. On the other hand, it may engender greater collaboration if there are limited resources. Maybe we are more inclined to work together rather than risk duplicating things. We look at ways to complement one another better and engage in partnership approaches where we share the resources and enhance intersectoral and horizontal service integration at that local level. So we need to identify exactly where the final responsibility lies as well for these imperatives. Performance and funding agreements need to be clear about where the accountability lies for the expected outcomes. But at the same time, those agreements need to be flexible enough to respond to different and changing needs at that local level. It can also encourage the development of scientific, technical expertise and leadership at that local level. But in countries with remote areas, and Australia, of course, is a country with very remote areas, it may just simply not be possible to move expertise out from the central level to the local level. So there's a risk also in moving expertise outwards that you hollow out the expertise at the central level. So you go back to having bureaucrats that are career bureaucrats without necessarily having technical expertise. And when I think about the early response in Australia to AIDS, I think the bureaucrats that I worked with were fantastic. And when I think further, I think that's because they were personally committed and passionate about the area. And I'm not sure that career bureaucrats necessarily do. So unless quarantine, public health funding may be exposed to local budgetary constraints, forcing it to compete with more immediate needs, acute care services. I was on the local health authorities board, and every meeting this played out as I pushed for prevention and health promotion, and they worried about people waiting in the emergency centre, which, as I referred to before, was much more likely to end up on the front page of the newspaper concerning the minister. So the Cinderella health fields, as I call them, were stigmatised, often hidden populations, homeless, sex workers, alcohol and drug dependent, those living with HIV, TB, hepatitis, mental health, prisoners, those with disabilities, they are most at risk. Okay, so the importance is, as I say, to achieve the right balance, nurture political leadership at a local, state and national level, develop methods to measure outcomes and establish systems to monitor these. develop and communicate approaches that are knowledge, science and evidence informed, support structures that encourage effective advocacy for such approaches by the affected communities and other expert voices at all levels, and educate the broader community about the societal value of achieving the right balance between prevention, treatment and care, and short and longer term health needs to ensure health for all. Thank you.